me that we still are on pagers. You guys are just on mobile phones. So most of the time in most hospitals, the code stroke or the acute stroke, I believe that's how we started. We had a stroke helpline in form of a mobile, and we would call all the team, come here, come here. So recently, what we've developed in our hospital, and this is still under the testing phase, trying to reduce the time to treatment, is developing of a code stroke. Now, what this code stroke was, since we do not have uh, the paging systems, we developed something on the EPBX, the hospital EPBX. So what we do is we have coded all the phones of the hospital. Chiefly, the main important part is the parts of the hospital where you have high incidence of stroke. And we have a specific code which we dial, and that once we dial that EPBX, because that's linked to a server, and the server passes on an SMS and a phone call to the entire stroke team. So what we get is basically dialing a code stroke. We believe that the time to activate the team is going to be reduced, and so would be the door to needle time. We are going to be coming up with the data with this in the next 1 year. We currently, the hospital staff is undergoing education for this. So this could be one other thing that, if shown, that we could of course propagate the use of the code strokes within the hospital. Again, the stroke unit care, this has been well talked of. We all know that stroke unit care is very essential, cuts down on mortality of strokes, has patients come out with better outcomes, or have a greater chance of going back home alive and independent. Now, this is the history how it all started. The first, of course, the elements of stroke unit were talked of in 1950, but at that point of time, there was no specific stroke unit care as what is now known, which can be closely thought of in 1970, which can be probably the first comprehensive acute stroke unit where multidisciplinary teams were included in the stroke unit. And this was central to the Helsingborg Declaration. Importantly, stroke unit care, one needs to understand this fact. Compared to thrombolysis on one hand and stroke unit, this probably has greater impact in bringing about better outcomes in stroke. Why? Because most of the patients who undergo thrombolysis is a small percentage, whereas 100% of patients, if they go into a stroke unit, you're going to have better outcomes. So that needs to be understood, how stroke unit care can really make a lot of difference in stroke outcomes. Stroke unit care is basically a continuum going right from nursing and assessment down to treatment and rehabilitation plan and discharge. And this I've already talked of. Importantly, like I said, the public health impact is massive compared to thrombolysis, which needs to be understood, and maybe research carried on stroke units needs to be now started in our country. The evidence is very, very scarce. We do not have enough evidence to show that, especially in the lower middle income countries. Whatever we have is a small number of studies from the lower middle income countries which did show that they favored the stroke unit. Now, these are a few of the current studies done, but still the data is lacking. And so this has led on to lack of policy. Cost, access to care, I've just talked of. Typically, TPA is not affordable to most of the patients. It was just discussed that some of the states have made it free. What I'm aware of, it's been made free in Delhi, Himachal, maybe Uttar Pradesh, and I don't know if it's done in Tamil Nadu. In one of the studies from South India, it was found only 30% of patients reached within 3 hours. Post-stroke, 16% of them were eligible. None of them could afford it. So even if they were eligible, they didn't get it. And this was back in 2011 that it was published, not many years back. So even if the affordability and the per capita income has improved, I can tell you in our hospital, we thrombolyze around, it's a public sector hospital. So you do get patients who are from the government sector and they are covered by the hospital, covered by the government. So we thrombolyze at most around 25% of the, 30% of the eligible patients, not all patients. So 30% of eligible patients are still thrombolyzed in our setups. But those would be high volume centers. So that needs to be also, again, a public policy which needs to be stressed onto the government to get it on a national level. If TPA gets free, that could be one. But I can still consider that as a very small component of improving patient care. So rehabilitation is again a chief, that's the last part I'm going to take. Rehabilitation, because rehabilitation services again are not very well developed in our country. Most of the patients do not have access to them. patients straight off get discharged to their homes, and most of the care is given by their relatives. And those relatives are not trained. So, and they do a kind of a untrained rehabilitation, which of course results in not very good outcomes. And there are very few rehabilitation centers. Now, these, even the paid caregiver, they don't go very frequently, and maybe the quality of the rehabilitation which is being offered to patients may not be very high. And in one of the papers from Bengal, in the rural areas, 50% did receive immediate attention, but only at 1 year follow-up, there 7% was still bedridden, and recovery of speech was seen in 47%. And women, they received much less attention, and that's probably the reason I Am Woman is the campaign by the WSO. Rehabilitation centers are there, but interestingly, only 2 to 8% of disabled population has an access, and I can clearly, or I would with confidence tell you that most of these patients are going to be orthopedic patients, because wherever I see rehabilitation centers, or even in our department, in our hospital, the physiotherapy and rehabilitation is chiefly for orthopedic patients. That's because in one of the reasons it's the HOD of our hospital is an orthopedician who shares the responsibility of the rehab department. But that would be true in most of the settings. The disability due to orthopedic diseases is also on the high. So what is being done about this is the ATTEND trial, which is currently ongoing. It's one of the very few trials which is being specific. It was catering to the setups in India. It's a multi-center study only designed for the domiciliary care or family-led rehabilitation after stroke. So the recruitment is ongoing. It's as planned. The recruitment is going at a very good pace, and the paper would be expected in the WSC in Hyderabad next year. All I can now add on is the areas which needs to be stressed on is inpatient rehabilitation services, which I believe are very limited. Again, possibly hospitals don't consider them as very profitable. In an inpatient occupational therapy, rehabilitation, an area which is now coming up is mobile app based. Everyone's got smartphones, and a good percentage in India especially. We were surprised because we are currently into one of the development of one of the apps in our institute, and 85% of our patients were whatever strata they did carry mobile phones with apps, and they were willing to use apps for their stroke rehabilitation. Only a single paper which has been published for stroke, that's in fact from Andhra Pradesh in collaboration with the UK group. And this Care for Stroke is a web-based educational intervention for management of physical disabilities, and it's basically designed for stroke survivors. So this is one area I believe where the future holds some promise, and mobile app based may become a major, I would say, source of rehabilitation services or a resource for stroke treatment. The research in India currently, I could find most of them are, like I said, large population-based data or research is chiefly registry-based. So these are the various registries which have almost been completed: Inspire, Interstroke, Pure, the Indo-US, where a few centers we were also part of this. SITS India, currently SITS has also started. Myself and Professor Padma from Delhi, we are the national coordinators for this, and we have been trying to recruit stroke centers across the country. Unfortunately, the only problem we face is all stroke centers who join the SITS registry are unable to make the entries. That's because they lack staff, and funding is a major issue. So even these are the other problems that we usually face, even collecting data on ready-made registries which are online. So other potential research areas from registry-based research, I would think that intervention-based research is what is needed on the current day, and India needs a lot of large volume, large population intervention-based research. A novel education strategies, awareness strategies on a national level, which ISA does propose to take up. EMS development with pre-hospital notification to reduce the time to treatment. The basic stroke unit and stroke-ready hospitals, these need to be really start having a development in our country. on a national basis. Again, this would be a policy decision, just like coronary care units came up in our country. It is, the next future is of the basic stroke unit. App-based rehabilitation strategies, the MAPS is our program which we are starting. Access to care by having free TPA at a national level is probably another thing which these are advocacy issues which someone has to push, including the ISA, which we would be pushing soon. Telestroke is something which I didn't touch. I'm sure there are lectures here on telestroke. So that, of course, holds a lot of future lot of potential in the future. So what I believe, the future is already here, so we don't need to really wait up in the future. The time is now. We have so many young physicians who have gone into the field of stroke, are doing very well. And these lines are very apt to development by Peter Langhorne in one of the studies on stroke units, where organized care pathways which are relevant and appropriate for an Indian context need to be defined, developed, implemented, and evaluated. So stroke systems is what we need to be looking at to really make a difference in large populations. Thank you.
So we have to move to the next speaker because we are delayed for about 15 minutes. So. So he's preparing his slides. Perhaps if there is any question. Yes, please. Dr. Khurana.
Second one is developing an EMS system which is efficient and able to understand the stroke gravity. Another system which I was thinking for long is at the level of the university for undergraduate and postgraduates who did MD and other things. The emphasis on neurology, emphasis on the stroke has not given as much as we give for myocardial infarction and cardiac arrhythmias. I think certain stress in the education systems, what we provide to the undergraduate and postgraduates in other discipline is also important in developing the importance of this particular entity to be brought into.
Agree. Automatically happen if physicians who are teachers in the medical colleges, they themselves would get educated on this. What I can see in the past is most of our teachers, they were from a time when there was no thrombolysis, there was no acute stroke readiness, or strokes were just treated as potential candidates for exercise. So I believe with the new generation coming up, this should make a change, and in fact the undergraduates would, just like the change that we are noticing in the postgraduates now, the MD candidates are very well now aware of TPA, which they were not maybe a decade back or even 5 or 6 years back. They all know about TPA, they are quite well conversant with it and accept it very, very easily. So if the next change which should happen at the undergraduate level is going to be with the new generation of teachers, I believe.
Which will end the session today, and then we'll have a tea break. And I promise folks, we have quite an excitement going on this evening. The events include some musical programs. Dr. Qureshi also wants to give his manuscript, his book, Scientific Art of Manuscript Writing, and he wants to do it in a way that either a best poster, and if not, we'll just take a draw and give one of the postgraduate students here. He'll sign the book and he'll give it to, that's what he wants to do this evening or tomorrow morning. Next speaker is Dr. Rakesh Khatri. Dr. Khatri is the director of the Stroke Care Now network, which is basically a telestroke network of more than 26, I believe, or maybe more than that, of spokes. He pioneered that in the state of Indiana. And also he's the director of the vascular neurology, director of the neurocritical care, and also the director of the neurointerventional at the Fort Wayne Neurological Center. I can still keep going on, but in the interest of time, Dr. Rakesh Khatri, please.
How many people have personal experience with telestroke? Just raise your hands. So I see one here who is not from US. There, okay. So we have a few. While they're working on that, let me just keep you engaged. How many of you want to learn about telestroke? Raise your hands. Good, I'm glad. Looks like we are 20 minutes late and it's time for your tea break. So these are my disclosures. I'm speaker for Boehringer Ingelheim and Medtronics. So main thing today we'll talk about in next 20 minutes and hopefully less is what is telestroke? Why do we need telestroke? What is role of neurologist in telestroke? Why can't we just ask any other physician to do telestroke? Different concepts and applications of telestroke networks. So telemedicine is not old. Telemedicine is just use of telecommunication technologies to provide medical information. It could be fax, email, or telephone. And in 1990s, they tried to do audio and video and felt this had a very bright future. Levine and Gorman were the first one to coin this term telestroke. So this is schematic illustration of telestroke. As you can see, I'll just put the cursor. So this is a physician probably sitting at some hub hospital, and he is evaluating this patient remotely using an audio and video platform, as well as through a DICOM server, which is a standard for transmission of medical information. He is receiving imaging and making a decision. So what we already know, I'm not going to go over. What we already know is telestroke is as reliable as bedside evaluation for a stroke decision point, like TPA or no TPA. That's the main decision we are going to make. And it's as reliable, you can make decisions. Other, why not just telephone? Because of stroke mimics. It has been shown in stroke doc trial that it is much better than telephone. You make a more accurate diagnosis. Is there any need for telestroke? So this question has mainly two parts. One is demand and supply. Demand, we have been talking about stroke burden today, so I won't try to go much into details. And supply is who are the experts who can answer that question, TPA or no TPA. How neurologist expertise change outcome in these patients. So this in general, we know there are a lot of stroke, and I won't go through this, but supply would be more important. Neurologists in general, even in United States, it's only about 4 neurologists per 100,000 people. And further specialized neurologists who deal with vascular patients is less. Growing number of neurologists, as you would imagine, are opting out of call coverage due to poor lifestyle when you cover a stroke patient. The United States is a fairly large country with very small population compared to India, so there are several areas which are quite underserved, and as far as neurointerventionists is concerned, there are about 550 neurointerventionists to cover the whole country. So definitely there is a demand and supply that justify telestroke. How neurological expertise change outcomes. This was the first study that showed that inpatient coverage by neurologist, it changes mortality as well as lower the disability when patient is being taken care of somebody who knows what they're doing. This was the second project that actually was an interesting project. They divided the hospitals into two, where they provided tele consultation versus just the standard way of doing things that they were doing. And what they found is, again, they were changing outcome. Death, institutionalization, disability, that was better. TPA, if you had tele network, they got 80 TPA compared to actually only 4 TPAs in the other control arm. Higher proportion of patients also had more expedited and appropriate workup like CT scan or carotid ultrasound, and also simple things like standardized tests for dysphagia before you start feeding the patients. So telestroke is not just availability of neurologists. Like, if you want to, there are a lot of neurologists who are very smart, but they are unfortunately not available in rural India or other parts of India where there is a need. So it's not just making them available, but making them available on an expedited basis. This is the most important point for telestroke. It's certainly a race against time. Even in United States, when you take different population data, the rate of TPA utilization is still about 5% and some places 8%. Unless you have a very dedicated telestroke or vascular neurologist in an academic center, in certain cities they have higher rate, but overall in general, these are the rates, up to 5% or so. Every 15 minutes, improvement in door to needle time, it improves mortality by 5%. I think this is a very important part to know. We all know about 2 million neurons per minute, but this is something, if you are not doing something for every 15 minutes, just imagine, you are killing people. So do something. Call people, make calls, transfer the patient. Just don't sit on the patient and do absolutely nothing. Endovascular treatment has emerged as a new additional standard of care along with TPA, but utilization is less than 1%. So hopefully in the United States we will see the surge, and already we are seeing a significant improvement in the numbers. So what is the role of neurologist in current telestroke? If you see a patient remotely, what is neurologist supposed to do? One thing, they would examine NIH stroke scale, review the labs, do a head CT, make a decision, and that's all. If you ask emergency room physician, what is your expectation from a neurologist? That's what they want. TPA or no TPA. They do not want anything more from neurologists. So there are several studies, and this was also in my own personal experience. TPA utilization does increase. In some institutions, tenfold increase if you have telestroke just because of availability. Also, now the second question has come in my own personal experience. I had a meeting with my ER physicians and I asked them, okay, other than TPA, what do you want? Their main concern was, okay, endovascular, no endovascular. That was their second question. They do not want much more. So they are really, ER physicians, they really want to help you, but you have to be able to triage the patients. TPA, no TPA, endovascular, no endovascular, and that's about it. So hopefully telestroke will help us answer. Now, if a neurologist definitely knows all the signs of a stroke, large vessel, small vessel, lacunar, they may examine the patient, gaze preference, aphasia, neglect, hemianopsia. They may decide, okay, should be a large, don't sit on it, transfer the patient. You do not have a CTA, CTP, but you have a clinical diagnosis there. Also, this is a new thing, clinical trials enrollment, and Dr. Qureshi had ATEC trial. He used medicine consultation that was allowed in his trial, and trial enrolled 1,000 patients, and is now they are reviewing the results. So there are different type of telestroke models, but we will talk about two models that are being used. One is hub and spoke. Everyone is aware there is a hub, and then there are several spokes. Typically, these are the two ways: drip and ship, where you start TPA ship for comprehensive stroke services. Other is drip and keep. So maybe due to some reason or the other, you decide not to give TPA, or you decide TPA and keep them. So that way hub spokes can keep those patients. However, what other next more common model that is coming out in the United States is third-party vendors or distribution model, where there is a group of neurologists or a private company providing services to several hubs altogether. And these hubs have their own several spokes, and they can have their own regulations to decide where patient would go. To their respective spokes can go to hub. The advantage of this is financial gain. The third-party vendor will be supported by different hubs, so that way one hub is not financially burdened. And this model is certainly becoming very common, and this is what we follow. I am in a private group. We are a group of 13 neurologists, and everybody takes call for telestroke. There are two competing regional hospitals, which are our hubs. We have 26 spokes, and they are well spread out. So essentially, it works out very well in order to cut down the costs. So telestroke is a win-win situation for hub and spoke, as well as on a larger basis for society. As you can see, hub hospitals will get neurology transfers. They will also do procedures like endovascular and surgery. Spokes will also avoid transfers in patients who do not need transfer. Now, usually if you do not have a telestroke consultant, out of fear of litigation or whatever, or you are not sure whether patient definitely would benefit or not, you would want to transfer every single patient. What we have seen in experience is up to 40% of patients, the spokes are keeping them. They are transferring 60%. Before, they were transferring much more. No EMS bypass, high quality patient care is provided by neurologists. And on society basis, you can see improved outcomes due to TPA, so lesser disability, more return to work, less caregiver burden. But also there is some other things that Hub Hospital is responsible for, like network support, neurological support, so making sure neurologist is getting paid to provide the service, IT costs associated with it. Some of the spokes hospitals, they also contribute to this IT platform. So they may see enrollment fees, hence there is some greater cost of care in that regard. However, what in our experience we have seen, if they can give one TPN that essentially gets all the money back for the whole year. So it's just one case and it saves you enough. Quality monitoring is much better if there is a telestroke because of the stroke coordinators which are involved with this. Now let's talk about technology piece. Technology is hardware and software. We will not talk about software. There are several proprietary softwares that you can use. Main thing is they should be HIPAA compliant, and that's just the standard. Otherwise you cannot use, typically in the United States you cannot do a FaceTime or just Skype. Not that you would not ever do it, sometimes you may be forced, and that's how they actually realized, but because of the HIPAA compliance, they do not allow that. So there are several other vendors who provide software, and so is hardware, or you can make your own hardware. This is something that we can build. Any hospital can build this. This is just a monitor, a camera, and these cameras can be controlled remotely if you want to zoom on a person. And essentially this can be a wired connection where you are charging the battery, you take it around wherever stroke patient is and provide the care. This is what we were following until 2011. And then we moved on to a different model. We'll talk about that in the next slide. But this is kind of state of the art where you would have a more robot that will actually come wherever you want it to come. It essentially sits somewhere. As soon as you press a button, it will kind of separates from its wall outlet where it was getting charged. It will come to your room. There, telestroke specialist will be there on the other side, and it will even move with you wherever you go. You don't have to push it. So, however, this is much more expensive hardware piece. Typically, this company, when I spoke with, just to lease it, it's about $2,500 a month. So that's substantial when you have a big network like 25, 26 hospitals. How do you support every single hospital having this piece of equipment? So we went something simple. We tried iPad. And iPad is something that, okay, you have some disadvantages. You don't have zooming capability, but you can change it. You can put a zooming lens as well. But iPad will give you an answer to make TPA or no TPA decision. And that was our experience, that we actually cut down costs significantly in our network. More and more hospitals actually joined in because it was so cheap. And remotely we evaluate the patient. Our neurologists, they walk around with their iPhones. And wherever, let's say they are having dinner with the family, they get a call. Everywhere in United States, usually, most of the places they have good Wi-Fi connection. They go, connect, evaluate the patient, TPA, no TPA, endovascular, no endovascular. These are the only two questions they have to do, and then they're done. So this works really, really well. Now this is a new one, Google Glass. Google Glass, some of the companies have really, there are two main companies that make it in the United States. They made their own proprietary software, and Houston is trying it, one other company is trying it. Some companies have approached us to try this, but I think this will be the future. You just put it on, your EMS can put it on, your ambulance guy, ER physician, anybody can put it on if they know let's say they know some NIH stroke scale. As they are examining, you are there on the other side evaluating the patient as well. And this is really, really cheap technology. So I think, do we really need those sophisticated robots? No. As time evolves, as technology evolves, it will become more cost efficient. And I think it will become more affordable. So this you all know, teleambulance and mobile stroke unit. Now teleambulance is mainly that you keep some kind of platform where you are transmitting the information. But mobile stroke unit is whole comprehensive thing. There is a CT tech, a CT, a neurologist who sits in the ambulance, decides, they can run the labs. Sometimes you can finish giving TPA even before you hit emergency room of the main thing. This was started by German guys, and what they realized is that door to TPA was 25 minutes, or they could substantially decrease door to TPA. That actually became more popular now in the United States. They are bringing it up. There are 3 places where they have brought it already, and they're testing it. But issue with this is cost. No neurologist is free enough to just wait and then climb in the ambulance and go with them. So I don't think, in scheme of long things, mobile stroke unit would be cost effective because of that part. So they need to have that tele part. They need to have teleambulance kind of model. They could have a CT scan there. You can evaluate the patient, do a CT, draw your labs. For that, neurologist is not required, but neurologist is mainly required to decide TPA or no TPA, and that decision can be made sitting remotely as well. So there are some reviews about mobile stroke unit, and it may result in overall shift towards earlier evaluation and treatment with TPA, particularly into the first hour after symptom onset, leading to substantial better outcomes. Cost is definitely a big concern, but they propose that it may be offset by reduction in cost of long-term stroke care and an increase in quality-adjusted life years. So far what we have talked about is acute stroke evaluation. Patient comes, you did your stroke evaluation, gave a TPA. But how about expanding that a little bit more integrative stroke care? As we were talking about before, Dr. Khurana mentioned pre-hospital evaluation of these patients. Emergency room evaluation, all that can be covered by what we have talked. But how about in stroke unit? And how about in ICU? Let's say remote hospital decides you give TPA and they keep him. Now in those stroke units, there can be daily rounds by neurologist remotely. You don't have to be in-house in order to review the CT scan, in order to tell the parameters. Now you do echo, now you do ultrasound, you make your decision, you need carotid endarterectomy or not, or you need, let's say somebody has AFib, you decide about anticoagulation. So all that decision can be made remotely. And then tele-rehabilitation, which is definitely a new one. I think the future will lie in multi-presence. As technology is becoming more affordable, more available, there will be several physicians who would be able to come on screen simultaneously and decide the best course for the patient. ER physician, just imagine a patient who is being evaluated in an emergency room by ER physician, neurosurgeon, neurointerventionist, neurologist, patient caregivers. So you can all discuss about consent part right then and there, decide what's the best course of treatment. So multi-presence is what I believe would be the future. Not only it will be ischemic stroke, but also it will expand to ICH and subarachnoid hemorrhage if we do have neurosurgeon and neurointerventionist coming on the platform. But there are some barriers, as definitely every telestroke. Main thing what in our experience we found is promoting physician adoption and participation. That took us almost a year before our neurologist got comfortable evaluating a stroke patient and deciding about TPA point. So there is a big learning curve about this. Neurologist who does not want to take calls or who likes outpatient neurology more may not really adopt this idea. It may take a lot of effort. Physician licensing and credentialing is a big deal. Like for us, we had to get credentials in every hospital. So all 26 hospitals, we had to get credentials, and there is a lot of paperwork and a lot of work that goes into it. Also, across the boundary, like we cover 3 states, not just my state, but also adjacent 2 states. There they have different licensing requirements, and you have to do all that. Medical liability is still a very hot topic. What if your telecommunication audio-video platform breaks down? You decided not to give, or if you give, but documentation is not appropriate, or ER physician did not take care of the patient in your absence. Like we did have a scenario when neurologist said, okay, if blood pressure is well controlled within these parameters, go ahead and give. And TPA was given, but blood pressure was never controlled. Nobody watched it. A guy was running in 200 plus all the time, came in with a big hemorrhage. So all that medical liability, who is responsible now? Neurologist who decided it, or ER physician who did not manage it well? All those are hot topics. Compliance with privacy and security law is very, very important. As we talked before, the HIPAA compliance, and finances. Finances is a big roadblock for this, but hopefully in future it will become more affordable. And limited reimbursement. In United States, even though we do telestroke consultation, reimbursement by insurances is very small or none in several states. So essentially, we have to make a contract with the spokes and hub hospitals, how we get compensated in this kind of model. So in conclusion, telestroke need in community is very high. Neurologist availability is important, but expedited availability is much more important here. Telestroke leads to more TPA utilization. It is definitely going to be cost effective. Technological refinement is expected in near future. Barriers are real, but certainly future is bright. Thank you.
That's what people used to say, Skype.
Yes, but Skype, most of the hospitals don't allow Skype just because of HIPAA. They are super big on that. And there are several, like Cisco has their own. There's several vendors, Polycom, Cisco, Video, VC. VC is fairly big too in the United States. But I think Hyderabad, given software engineers here, and plenty and very brainy, wherever in United States I go, I meet a software engineer, he's from Hyderabad for some reason or the other. So looks like you guys are so bright, you would be able to make it at home and all HIPAA compliant. But I think this technology can be easily developed. Okay. Thank you very much.
Thank you, Dr. Khatri. So that ends the session. I would request all the delegates, to let's take a break right now, a tea break. But a quick reminder: we'll be reassembling for workshops, and the way they are designed right now, we'll have 2 parallel workshops: a neurosonology workshop coordinated by Dr. Komal Kumar from Yashoda Hospitals here in Hyderabad, and the other parallel workshop will be a neurocritical care workshop coordinated by Dr. J.M.K. Murthy here. So the faculty for neurocritical care will be Dr. J.M.K. Murthy, Dr. Adnan Qureshi, Dr. Subbareddy from Apollo Hospitals, and Dr. T. Aditya from Yashoda Hospitals. And the faculty for neurosonology will be Dr. Komal Kumar, of course, Dr. Fawad Abdullah, Dr. Alex Georgiadis, and Dr. Y. Mulidhar Reddy from Care Hospitals. Unfortunately, the delegates have to choose between the 2. We'll split into the 2 rooms in this ballroom here. One will be neurosonology and the other, of course, neurocritical care. It's a 1-hour workshop, and after that we'll have a common workshop of neurointervention. And the faculty for that will be, as listed in the brochure, Dr. Adnan Qureshi, Dr. Rakesh Khatri, Dr. Amir Hassan, and Dr. Suresh Giragani. And we'll have 4 workstations: aneurysm, thrombectomy, thromboaspiration, diagnostic angiography, and the other one is AVM, embolization. So 2 hours of workshop, and then I promise it's entertainment time. We have guzzles, we have poetry, we have good food, of course, and it'll start at 8 p.m. and it can go on. And we'll have before that a collection of all the speakers and faculty will be on the dais, and we can talk, we can extend our question and answer sessions, or, and we'll have some lay public also join in the evening. So it'll be a complete stroke awareness program. So we'll talk about stroke. We'll hear from Dr. Adnan Qureshi for the first time today, addressing the crowd. We'll hear from Dr. Dheeraj Khurana. We'll hear from Dr. J.M.K. Murthy, from Subhash Kaul, if he's here, and all our chairpersons as well. And then we'll move on to the cultural programs. Thank you so much. Enjoy your tea. Thank you.
I would like to thank Dr. Adnan and his team for putting up this workshop. This is actually, this will be a very busy hour because 1 hour is too short for neurosonology workshop. And then I want you to be more interactive. So we'll have a brief short talks on carotids and then TCDs, followed by we have lined up few cases which are very interesting. And then I want the audience to be part of this workshop. We have Dr. Fawad and Dr. Georgiades will be joining us. So we want to utilize their expertise to the maximum. Be selfish, because they're not going to come again and again. For the first talk, I invite Dr. Amit. Amit is a senior neurologist and neurosonologist. He's practicing in Max, New Delhi. He will take us to carotids.
Dr. Komal has made my job tough. He's already given us a time limit, and to finish everything about carotids in 15-20 minutes is going to be tough, but I'll sort of try to run you through these slides, and then any questions can be taken up during the live demonstrations. So I would just begin my talk with this quote by Karl Popper, who said, "True ignorance is not the absence of knowledge, but the refusal to acquire it." So this is what sums up the attitude of, oh sorry, somebody will have to help us. Oh, it's there, okay. So this is what sums up the attitude of most of the neurologists, and unluckily even many of the stroke neurologists towards neurosonology. So you have a tool which is bedside, which is non-invasive, quick, reliable, reproducible, and gives you a wealth of information, but still we don't utilize it to the maximum. We depend on our radiology colleagues to give us the answers for the stroke. We treat stroke, but we look for the mechanisms, the answers from a radiologist, which is very unfortunate. So it is our endeavor to try to spread knowledge about this and involve more neurologists to do it on their own. The indications for carotids, this is a very busy slide, but believe me, indications are much more than what I have mentioned here. So most important and most common one to use is evaluation of patients who come with hemispheric neurological symptoms, including stroke and TIAs. Then it has a very imminent role in preoperative evaluation of cardiovascular surgical procedures. I don't know how much it is practiced here, but across the world, for all patients who are undergoing CABGs, doing a good carotid ultrasound and clearance from the neurologist is the rule. Then evaluation of unexplained neurological symptoms, syncopes. So the carotid can help you a lot. Follow-up of patients who have proven carotid disease. So you see a patient who's had a stroke and he's found to have a 50% stenosis of the ipsilateral carotid. You want to put him on the best medical management and then follow him. You don't want to do CT angios every 6 months, the cost plus the radiation and also the effect of the contrast. So it is the best modality which can help you follow up these patients and subject them to any intervention if required over the course of the disease. Then intraoperative monitoring of vascular surgery. So when you're doing a CA, you need to have a machine in the OT. So any re-occlusions, any hematomas forming there, you need a ultrasound to be there. Then after you've done the carotid procedures or the stents, you evaluate these patients post-operatively with the carotid ultrasound. Then a very, very important role is in evaluation of suspected subclavian-steal syndrome, which many of us miss. And this is the only test which can show you a significant subclavian-steal syndrome in real time. Angios can just show you that there is a subclavian stenosis there, which is very common in atherosclerotic patients. But whether this is causing any hemodynamic effects, only the carotid ultrasound along with the TCT can show you. Then also evaluation of carotid artery dissection, AV fistulas, and evaluation of patients with an cervical bruit which may not be of any hemodynamic significance. I'll not go through the anatomy, all of you are well aware of it, the carotids, the vertebrals. So what is all that you need to do it? The machine is the routine ultrasound machine you have. The newer ones are the better in terms of their grayscale or the B mode resolutions, but any machine, whichever you have in your hospital is good to begin with. The probe which you use is a linear probe. For very thick muscular neck, sometimes you might use a curved probe, but linear probe is the best, and you need to use a high frequency probe, at least more than 7 hertz, because the higher the frequency, better is the resolution, though less is the penetration. You don't need penetration because arteries, carotids and vertebrae are very superficial. So all that you need is a better resolution to look at the intima, to look at the plaque. So a linear probe with a high frequency is all that you need. So how do you do it? The patient should be examined in the supine position with the arms by the side, relaxed in the bed, and your head should be turned at least 30 to 45 degrees away from the side when you are doing it, right? And you should avoid using a pillow, because if you use a pillow, you are flexing the neck and it might be difficult to reach the bifurcation, especially if it is higher up. So better to not use a pillow. And in fact, if there is a short neck, it is always better to use a pillow which is kept below the shoulder. So that way you can hyperextend the neck and you get a better field for examination. The position of the examiner, these two positions are commonly used, whatever way you are comfortable. Either you can sit behind the patient overhead and then you use the right hand for the right side and the left hand for the left side, whatever way you are trained. Or what most radiologists do is the lateral sitting position by the bedside. So you use the right hand for both the sides together. So none of them have any advantages or disadvantages. It is all your convenience and how you have been trained for it. And the position of the probe again depends on what artery you are trying to insunate, and second thing is what is the status of the neck, if it is short neck, thick neck. So anterior one would be more imperative for when you are trying to insunate the common carotids, and once you reach the CCA bifurcations, you need a more posterior approach for reaching the ICS, or a lateral approach for the vertebral arteries. And also depending on where you get a significant stenosis or a plaque, you need sometimes, and depending on the individual variations in the anatomy, you might have to change the probe positions to get the best view. I will not go into details of physics, but I will just tell you that you first need to acquire a B mode image, that is a plain black and white image, because that is what will best show you the wall, the intima, the presence of the plaque, its characters, and also assessing the degree of atherosclerosis, and this is the one which gives you the best resolution. Color Doppler, you can apply a color Doppler on the B mode just to see the blood flow in the vessel and finding the stenotic segment, also looking at the turbulence. But once you use the color, you have a trade-off, so your B resolution goes down. So don't be too enthusiastic in using the color Doppler all the time. B mode is the best. And a power Doppler can be used whenever there are tortuous vessels, very slow flows, or when there is a very narrow lumen which is almost going to near occlusion. So power Doppler can help you. It does not show you the directions, but it is good for picking up these slow flows. And after you've done this, next is the spectral Doppler, because this is what will quantify the stenotic segments. This will give you the velocities, and you can find out the degree of disturbance because of those stenosis, and you can quantify it depending on the criteria which I'll be showing you. So this is how you classify it, and then you send those patients for any interventions if needed. So this image on the left is the B mode image. And this is the color Doppler, that's the power Doppler, and this is your spectral Doppler. The carotid scanning protocol, you first start with a transverse sweep, right? And you begin as proximal as possible from the proximal CCA, and after you moved up to the bifurcation, taking both the ICA and the ECA, you don't need a sweep for the vertebrals, right? So first you do a transverse sweep, and then you move to the longitudinal plane. Again, even when you are doing the longitudinal plane, the screening, you need to insunate the proximal CCA, the distal CCA, the carotid bulb, then you go on to the ICA, the proximal ICA, the distal ICA, the ECA, right? So after you've done the carotids, then last of all you should go to the vertebral. So this is how you move, and you should keep the scanning protocol fixed for your lab. So if you are doing it or I do it, it is reported in the same sequence, so nobody has any ambiguity, no confusion regarding that. So this is how a transverse sweep looks like. You have an ECA which is of a lesser caliber, the ICA, and above that, that's the, sorry, I don't have a pointer, but that's the jugular vein. And if you put color into it, you can see both these arteries appearing red and the vein appearing blue in the transverse sweeps. And this is how a clean, good longitudinal common carotid would look like. Below is the CCA, above is the jugular vein, and you can see a very nice shining IMT there. And once you moved away from the proximal, you move to the distal CCA, and this is where you find a flow divider in the carotid bulb, and above is the ICA and below is the ECA. But how do you define which is the ECA and which is the ICA, right? Because the caliber is of no significance. Depending on if you have a degree of significant stenosis distally, the ECA might get internalized. So you need to have two parameters which are most important to differentiate between the ECA and the ICA. That is the presence of branches, right? So ICA does not have any branch in the neck. So if you should make all the efforts to localize a branch. If you see a branch from that vessel, that is for sure ECA, that cannot be ICA. Other method which many people use is the temporal tapping. So if you're insunating your vessel and you tap on the superficial temporal artery, if it is an external carotid artery, you will be able to see that this disturbance is there, which is the temporal tap. This again helps you to localize that is an ECA. But again, this is also not foolproof. So best is localize the branches. So this is the position for the transverse sweep. That's for the longitudinal. These are how the normal waveforms look like. On top is the ICA. So ICA is a low resistance flow. Below this is the ECA. ECA is a high resistance flow with a very sharp upstroke, very steep downstroke, and a very minimal diastolic flow. If you compare it with the ICA, the diastolic flow is almost minimal. CCA has signatures of both the ICA and the ECA, so you have a rapid upstroke, a decent diastolic flow, and below is the temporal tap, as I've already said. I will skip on this. This is all technical details. Okay, so what all to be looked into after you acquired your B mode? Intima medial thickness is something which is of great importance. Lot of interest these days is being shown into this parameter as a surrogate marker for atherosclerosis, not only in the carotid but also in the coronary circulation, right? So this is measured on a 2D grayscale image. You don't need any color for that, and intima media thickness of less than 1 millimeter, say 0.8 to 1 millimeter is considered normal. Anything above that is an increased IMT. So if you can see that those thin lines with the shining, that is the intima and the media. So so you have to just measure the IMT between those two lines, and that is the normal IMT, and here you can see a thickened IMT. Then next is if you have a plaque, you need to characterize those plaques. The parameters which you need to look into is, first of all, the location of the plaque. Say a proximal CCA plaque does not have so much of hemodynamic significance as the proximal ICA plaque. So you describe the plaque in all these characters. First of all is the location. Second is the echogenicity, whether it is an isoechoic or a hypoechoic. So hypoechoic or isoechoic is taken with respect to the surrounding sternocleidomastoid muscle, and you have to be very careful, because sometimes these isoechoic plaques are missed within the lumen, right? So when you do a B mode image, you might miss that plaque, but as soon as you put your color into it, a lumen which was looking normal is suddenly not filling, and then you realize that there was isoechoic plaque which you missed on the B mode. So that is where your color Doppler can help it, and these isoechoic plaques are very ominous because they are very soft, fresh plaques, and they have a high tendency for embolizing and causing strokes or recurrent TIAs. Then composition of the plaque, whether it is homogeneous or heterogeneous. So homogeneous means it's a very smooth looking plaque. Heterogeneous means there is a lipid core, lot of calcifications. So that is how you describe the composition of those plaques. Also you should have a look at the surface very carefully, because sometimes you can have a dip on the surface which may represent a ulcer, and ulcers have a very high thrombogenic potential. So a soft plaque, a smooth plaque versus a plaque which has an ulcer, your treatment strategies, your level of antiplatelets should change, especially if patients are having recurrent TIAs. And also you should be very carefully looking at the presence of a intraplaque hemorrhage. So on top, on that side, right, you see a smooth looking plaque, but there is a calcification in the wall. this is a heterogeneous plaque, and maybe there is also an intraplaque hemorrhage there. That's a normal, hypoechoic, but a very smooth plaque with a very thin cap on it, and this is a crater on top of this. So this is a ulcer on top of the plaque. So I don't know whether you're able to see that. That's again intraplaque hemorrhage. So when you put in color, you can see a flow reversal into that, the blue thing down. So that confirms your diagnosis of an intraplaque hemorrhage. And any guesses for this? That's a stent in situ, right? Video will not play, I don't. No problem. Okay. So this is carotid dissection. You might be able to see a intimal flap, which may not be there all the time. But again, you can see two lumens within one artery. You can see a flow reversal. So one artery, one flow is towards, and other is away from the probe. And videos I'll skip. And this is the criteria for carotid stenosis I was talking about. The most important parameters in this are the peak systolic velocity of the ICA and also the plaque estimates, right? Depending on how much percentage of stenosis this plaque is causing. So both of them put together, you classify the degree of stenosis. So don't go by the area stenosis, which most of the people tend to report, right? On a transverse, they take the area and divide it by the lumen and say this is the area stenosis. So for subjecting all your patients to any interventions, if you say it is 50%, 50 to 70, more than 70, close to 90, close to 100, this is what criteria is to be followed, not the area stenosis, right? And you have a secondary criteria which include the ICA over the CCA peak systolic velocity ratios and also the end diastolic velocities of the ICA. So as you all know, the NASCET trial has shown beyond doubt that CEA benefits patients who have symptomatic carotid stenosis more than 70%. So this is how you need to classify them and to be very careful. And a last word about the vertebral artery. Vertebral artery should also be performed as a standard. So most of the radiologists don't perform a vertebral artery duplex along with the carotids. They just do a carotid. So you should not be missing on that. And how do you do it? Once you have located your CCA, all that you need to, in a sagittal or a longitudinal view, all that you need to do is go more lateral, take the transducer lateral, and then try to locate your vertebral artery in between the transverse process of the cervical spine. And putting in a color will definitely help you localize this the vertebral artery better. So this is how your vertebral arteries would look: the vertebral artery below and the vertebral vein above, and a black thing which you can see in between is your vertebral the transverse process. You may not be able, there is no validated criteria for the stenosis as in the carotid. So there is no upper limit of the peak systolic velocity because of the tortuous course of this vessel. But at least you can look at the flow, the patency of the vessel, the direction of flow, or any flow reversals which might indicate either a total occlusion or a subclavian steal. So this is a flow reversal which is in a patient with subclavian steal. This is almost a completely occluded vertebral artery. You can just see some systolic spikes, and underneath you can see a vertebral stenosis with high velocities which are almost reaching approximately up to 200. So this is how you should report your carotid and vertebral duplex. So it should include the CCA velocities at the bulb, proximal distal, ICA proximal distal, ECA, and their ratios of the ICA versus the CCA peak systolic velocities, and also don't miss on the vertebral arteries, and also you should also comment on the IMTs, on the presence of the plaque, detailed its characteristic, because without that your report is totally insufficient. And I would like to conclude saying that carotid duplex is an inexpensive, bedside, reliable, reproducible imaging study. And when combined with TCD, which Dr. Pradeep will be talking about, it provides an excellent insight into the cerebral hemodynamics and the mechanism of stroke. So you don't need to depend on anybody else. You can do it on your own and see it for yourself. So I think I'll end my talk here. And thanks for inviting me for this talk.
Thank you very much. Now, Dr. Kumar will demonstrate.
Thank you, Dr. Amit, for keeping this
Yeah.
talk so short and simple. See, this is not a rocket science. This is very, very easy to learn, and it's an reproducible, repeatable, non-invasive bedside modality. Actually, we as stroke neurologists, once we start looking at these vessels, our understanding of stroke improves so dramatically. And we'll put up few cases regarding whenever you're doing these Dopplers, it is very important to sit at the head end of the patient. Sometimes it will be so embarrassing sitting at the side of the patient and then doing on both sides. I usually sit at the head end of the patient and do it on the right hand and the left hand. And whenever you're doing, when you're looking at the vessels, there are three things which you have to see. One is look at the lumen, look at the wall, and look how the blood is flowing. If you keep these three things in mind, it's very, very easy to do and then very easy to interpret. We'll just start with a normal individual first. He's a normal subject. Pointer here. See this. This is your common carotid artery. This is the jugular vein. As he sweeps up, sweep it up. Then as he sweeps up, no, axials only, axials. Sweep it up. See, go back to the bulb. So as he sweeps up, suddenly the lumen increases in size. Yeah, that is the bulb. Then go up. Then it bifurcates into ECA and ICA. So when you are seeing this transverse axial sections, this is most important because this is a thing which you can see a plaque and you can look at the vessel wall. And then most of the times you can even differentiate an artifact from the fact. Go to the transverse. This is the transverse section. And this is the intimal reflection. This is an intimal reflection. And then freeze this. Freeze, enlarge. And then you can measure the intima. Usually IMT is measured on the far wall, not on the near wall. You have to go down a bit, yes. So that is the IMT. Because since he is so young, it is absolutely normal. This is 0.046. IMT anything less than 1 centimeter is normal, more than 1 centimeter is plaque. And then with age, the IMT increases. And then you give importance to IMT only if it is more than 1 centimeter. And then go back. Then show the ECA and ICA. This is the bulb, and then, yes. You can put the color. Color is not projecting here. The problem with the color here? Put the power. Okay, ICA. ICA is actually larger than, it's a larger vessel compared to the ECA, and it doesn't have any branches, remember. Whenever you are seeing branches, it is most probably ECA, and the first branch which arises from the ECA is the superior thyroid artery. And go back to the vertebral. You know, just slightly rotate posteriorly, and then you see this vertebral artery. It's in the intertransverse process. Yes. I think there's some problem with the projection. Yes, that is the vertebral artery here. You can see that flow there. Okay, fine. This is a normal patient. You can stop here. Bring the patient. Projection is not proper. Is it clear? Is it visible? What are you seeing inside? Block, okay. As it goes up. there is significant stenosis actually. Okay, in the interest of time, just go to the longitudinal section. Go to the longitudinal. Yes, this is a CCA, and then you're already seeing a plaque there in the CCA. As it goes up, you can see here there is a significant stenosis here. It's more than. Suppose whenever you have a bilateral significant keratinosis, which one you intervene first? This is a gentleman with a young stroke. Yes. And then there is a complete occlusion actually. There's a complete occlusion here. Okay, fine. Then I'll show you a very interesting case which was initially mistaken as something else. And then it was found out after 6 months. Actually, the patient has gone to a radiologist initially for the Doppler.
Yeah. There is, yeah, there is a proximal ICA. It just appeared after the pulp, but it is the lumen showed marked reduction, and we need to switch on the color and to see also the external carotid. Yeah. Yeah. Almost no flow. Yeah. Trying to differentiate between the two branches, the internal and the external. Typical tapering occlusion. Yeah, for young people.
See, he has got a CCA occlusion. It's a complete occlusion of the CCA on the right side. And then, okay, go to the longitudinal. Go to the longitudinal. No, go to the longitudinal. Yeah, right. So you see, there's a complete occlusion of the CCA, and then go. Okay, put the color. Put the color. Yes. Track the ECA. Go to the ECA. See that. What is this? This is the ECA in which the flow is reversed. The ECA is supplying the ICA. This is what we call internalization. So the ECA flow is reversed and it is supplying the ICA. And then there is a complete occlusion of the CCA on the right side. Internalization. Okay, and then go to the vertebral. Vertebral. See, the vertebral is good. It's big, showing a good flow. Okay, go to the left side. On the right side, you have a complete occlusion of the CCA. There is reversal of the flow in the ECA, and ECA has internalized very well, and you have very good vertebral flow. On the left side, you see there's a plaque coming, and then as you go up, there is complete occlusion of the ICA on the left side. Go to the left vertebral. And if you see carefully, the flow in the vertebral is reversed. Okay, right. Before, I think it was in 2004. Okay, we welcome Dr. Pradeep. He will take us through the basics of TCD and interpretation of the various waveforms of TCD, and then we'll do a hands-on again on this particular patient which I have shown you last.
Can you connect it to this screen? Tell you the nutshell of neurosonology, especially the transcranial Doppler aspect of it. It's a highly useful investigation, as Dr. Amit was telling. It is very cheap, it is reliable, it can be done at the bedside. And it is repeatable. It's very cost effective also. So such an investigation is actually ideal, and I think all neurologists should be doing it, because I was very impressed with the lecture of Dr. Dheeraj when he was pushing the people for the new generation for the neuro interventions and this thing, because that is what it should be, because instead of being sitting in the armchair, you should come and start doing things, then you realize how interesting the branch of neurology is. It's not coming to this side. Excuse me. Excuse me. This is the brain. And God has designed the skull in such a manner, thought that one day some neurosonologist would come and access the vessels through the temporal area, because that is the thinnest part of the skull. So there is a thin area through which you can access the vessels of the base of the skull, especially the circle of Willis. I am not going into the technical details, which demands a lot of time. Another important indication is vasomotor reactivity, intracranial arterial disease. Of course, it is well known that in our country, intracranial arterial disease is probably much more common than extracranial arterial disease as a cause of stroke. We can assess it at the bedside. And of course, with CT angiogram and MR angio and DSA, you can assess it. But on the neurologist's office also, you can decide about intracranial stenosis. It is useful in acute brain ischemia, emboli detection, right to left cardiac shunts, intensive care, very useful, vasospasm detection, traumatic brain injury, ICP monitoring, and cerebral circulatory arrest. Perioperative and peri-procedure. This is the only modality which can detect emboli in real time. No other investigation modality can do that. Emboli monitoring useful again for acute stroke, dissection, right to left shunt, during carotid endarterectomy and CABG, as well as during angioplasty and stenting. This is a classical microembolus signature. And what about TCD in stroke? Extremely useful. It can detect an occlusion, site of occlusion. It can detect clot dissolution. It can detect distal embolization. It can detect reocclusion. How do you detect when a patient you have treated with thrombolysis, and the patient deteriorates subsequently? How do you know that this patient has undergone a reocclusion? This is the methodology. You can detect it in your intensive care unit, the patient has reoccluded. And it can also detect intracranial stenosis. TCT can detect the beginning, duration of recanalization when you are doing sonothrombolysis. It can detect the time to maximum completeness. It can also assess the amount of recanalization. I am not going into the detail. It can also prognosticate in stroke, depending on the rapidity with which recanalization takes place. This is the classical TCT signal. You get it with an acute stroke, which is known as this is the classical blunted signal. You get it in acute stroke. This can be correlated angiographically. This is in the posterior circulation stroke. This is the kind of signal you get. Can you increase the volume, please? Signal which you get. And this is what you see as you in thrombolysis, from a zero flow, which is called as a thrombolysis in brain ischemia flow, to a normalization of flow as the TPA is flowing. And this can be validated with your angiogram. Angiographically, the one on the left side shows before TPA, and after TPA, you see the basilar artery has opened up, and you see a normalization of the flow. So similarly, this is the thrombolysis in brain ischemia and correlated angiographically. Intracranial stenosis is another important indication for transcranial Doppler. There is hardly any vessel which we cannot detect having a stenosis. This is a PCS stenosis. See the velocity. We always talk of mean flow velocity in transcranial Doppler, not peak systolic as you speak in an extracranial Doppler. This is a PCA. This is a basilar stenosis. This is an MCS stenosis. This is again an MCS stenosis. This is a left vertebral artery stenosis. This is a left ACA, basilar. So, can you increase the volume? That's it. Yeah. You are hearing the bruit there, just like how you hear the bruit with your stethoscope. Basilar stenosis. I will not be showing the whole disease because it will take the whole day, but I just want to tell you certain things which we can do. This is a subarachnoid hemorrhage, which is another important indication for transcranial Doppler, especially in the ICU. You can detect the degree of vasospasm, especially after clipping or coiling. And another indication for transcranial Doppler is in assessing the intracranial pressure. See the ICP. See, ICP can be monitored using transcranial, which we use it very frequently in the intensive care unit. We know when the patient is getting drowsy, we always look at the TCT and tell whether it is due to a raised ICP, because many a time you are questioned whether it is an electrolyte imbalance or a raised intracranial pressure or some other factor. This tells us actually it is the ICP which is responsible for the steel. I think Komal demonstrated as subclavian steel. No, this is the classic. This is another very important indication for transcranial Doppler. This is the classical subclavian steel, and at the reversal, I will show you right from the basilar artery. Look at this. See, that is a ST. That's the systolic flow reversal which you are seeing in the, right from the basilar is reversed. Whenever the person uses the upper limb, this is due to the proximal subclavian artery stenosis. There are so many indications, but one more thing before because it's short of time, I want to tell you the utility of this thing in PFO, patent foramen ovale. Because, that is one of the common things which you have come across. Cryptogenic stroke, the person comes to you and after investigating everything, you don't know what is the reason for the stroke. You can do a PFO study. And in PFO, it is between, this is the classical paper in which this was the paradoxical embolism, which was transiting through the patent foramen ovale. And comparing transesophageal is the only so far gold standard for detection of PFO, but TCD is actually, I will tell, is superior to the transesophageal FCO. If you are used to doing it, you can pick up a PFO at the bedside within no less than 5 minutes. And it is very comfortable for the patient also, unlike doing a transesophageal echocardiography where the patient has to swallow a big tube through the mouth and sometimes sedation may be needed. This is a case of PFO. You inject agitated saline through the antecubital vein. See the microemboli signals. This is called as this will always qualify for a curtain or a shower of emboli, which is more than 300 microemboli, which indicates this PFO will need closure. You just mix 1 ml of air with 9 ml of saline, and it is given within 2 minutes. You have the answer to the problem. So this is one of the, I would say, one of the very useful indications for a transcranial Doppler. And here the beauty is that this can be done on a sitting position. Your patient does not have to lie down. You can do it on a sitting position. Then probably I will finish off with this last thing. That is, of course, dynamic TCD is for detecting vertigo for vertebral artery completion. Then another indication is for brain death. For a confirmation of the brain death, this is a very useful indication, especially with the present way in which we give organ transplantation, and most of the hospitals, major hospitals do it, and our hospital also is very much involved in it. And we're very often asked to give an opinion regarding the brain death. For 30 minutes, you insunnate your bilateral MCA, middle of the M1. That is 55 millimeter depth. You look at a 85 to 90 millimeter depth with the basilar artery, and if you see this kind of a flow, this is called as reverberating flow. That is, what is happening in reverberating flow is that in such a situation, there is no forward flow of blood into the brain. So in systole, the blood just hits at the blood vessel. So that is why you get the upward stroke. In diastole, the blood comes backward. So that is the reverberating flow pattern. If you see this flow pattern, you know the brain there is no forward flow taking place into the brain. So this is, if you record this in 30 minutes in both the MCS and the BASIA, that brain is not going to come back, 100%. So that is almost a confirmatory test for brain death, and I think I'll finish it off by just giving a concluding slide. It's a portable TCD, can be used at the bedside, repeatable, cost-effective, sensitivity and specificity comparable to DSA. I can very well tell that because I'm a person who is doing an intervention also. So I validate my TCD findings. Can be used for long-term monitoring, only modality for real-time emboli detection. Dynamic TCD is another way of detecting obstructions whenever in particular position the next, but it needs technical expertise. And thank you very much. Sorry I could not go through it, but I just wanted to give you a brief overview of what we can do with this investigation. And I think next I will we have the case.
Most important aspects of TCD.
And then we, as we do it every day regularly, we know that we can understand the importance of this very easy and then affordable, inexpensive, non-invasive modality in our day-to-day practice. Having come, then we'll keep that case, which again we'll take use of the TCD in this patient, and we'll try to understand what's happening inside his brain. And Dr. Pradeep, you want to take over? And then we have already seen his Doppler findings in the neck. We know that he has got complete occlusion of the CCA, and ECA is reversed and internalized, and then his ECA is supplying the ICA, and then on the left side, his ICA is completely occluded. But you see the patient is totally normal. Though he had few strokes, he is normal, and then he is moving all four limbs, he is normal in his daily living. So what's causing, then what is making him to be normal? Any idea? Just few comments. The ACOM and then PCOM. And then second order collaterals are your ophthalmic artery and your leptomeningeal collaterals. Let's see what's happening in him. Start. So it is completely occluded. The ECA is internalized, and then it is supplying the ICA. The ICA is taking the blood, and then it's going to the MCA. Can you just project it? Project. Can you project? Why? Okay. Then it becomes difficult. Projection is not working. And then PI is 0.59. Then just remember these velocities. It is on 68 on the right, MCA on the right side. Go to the ACA. ACA. Go to the next. Yes. Get a strong signal. Try to get a strong signal again. The velocities in the ACA are almost equal or slightly more than that of the MCA. Anything you want to comment?
That most probably is the PCOM, what we are seeing that, because there is no way in which velocity in the posterior PCA should be above that of the MCA. If that means that it is supplying, it is contributing to the flow to the MCA. MCA has a velocity of 63.5, whereas the other vessel had a velocity of 65. So the posterior circulation is now feeding the, because from the, he is the person who had that. He has, this is on whom the carotid was done, which showed a bilateral carotid highly significant. One side was occluded, the other side was also highly significant. So, and his vertebral is now supplying the anterior circulation. So this, for this, the carotid, it is coming from the other side, and the A1 is reversed on this side. A1 is reversed on this side. So normally it should have been a flow below the baseline, but here you are saying it above the baseline. Can you look at the ACOM also? Yeah, that is most probably you are dealing with the ACOM. That is the anterior communicating artery flow. Because that is a midline. How do you identify an anterior communicating? It is a midline depth, 75 millimeter depth, and you see here a bruit. Because you know these vessels are not always present. They open up when it is needed. That was told in the morning session also. These collaterals, you know, it need not be chronically developed. It is an abrupt phenomenon. We see suddenly a vessel is occluded, the other opens up. So similarly, the ACOM and the PCOM are normally not patent. Normally not functional. The bird is not patent, normally not functional. The moment there is an occlusion, it takes over. So this is a nice. ACOM, that is the ACOM flow. anterior communicating artery flow. Surely this must be having a reversed ophthalmic also. Reversed ophthalmic. Yeah, 2
Is up and about instead of having a complete occlusion on one side and a near complete occlusion on the left side. And he also has a reversal vertebral artery flow on the left side. I think with this we conclude. I hope this session is interesting, and then I hope more and more young neurologists will take up this field of neurosonology. And I thank Dr. Fawad, Dr. Amit, and Dr. Pradeep for making this hour very interesting. And finally I thank all my patients actually who have come all the way. One patient has traveled almost 200 miles to attend this workshop. I thank all of them, and have a great day ahead. I think we are already running late, and then people are waiting outside to take over this hall. Thank you.
All of the neurologists started to build up their career in the neurosonology, as it is a promising career, and we have to consider that the transcranial probe is the stethoscope of the neurologist. Like the cardiologist, they have their stethoscope for the heart, we have our stethoscope for the brain. And it is a bedside test, and it helps a lot in lots of diagnoses and prognostic implication, especially in acute stroke. In addition, the color and the P-mode duplex can be utilized quite a lot, not only in the vascular, but nowadays there is a subspecialty called myoneurosonology. You can use the P-mode high resolution P-mode to image the muscle and the nerve, and to go to a particular diagnosis of different pathology. So neurosonology is a promising field, and I wish lots of Indian neurologists to start their career and to build up their career in neurosonology, either in the neurovascular ultrasound or other neurosonological field. Thank you.
Penumbra and histodiagnostic workstation. There you'll be seeing on display the catheters that are used for thrombectomy and thromboaspiration, primarily thromboaspiration. And that station will be attended by Dr. Rakesh Khatri as a faculty member. So groups can rotate between these three workstations. We can split into 15 or 20 each or more if we have to. And the next workstation is run next to it. It's the microvention workstation. They have for us flow models where we use liquid embolic agents like their trademark component, which is TrueFill, that's used for AVMs mostly. So that station will be attended by Dr. Amir Hassan from Harlingen, Texas. And he has treated enough aneurysms, I think far more aneurysms than anybody else would, and he's a great person to attend to any clinical or technical questions that you may have. The other workstation will be right here inside. This will be a workstation which will be attended by Dr. Suresh Giragani from Yashoda Hospital. He will give us a display of diagnostic catheters that are most commonly used. And if you all know, diagnostic angiography is far more frequently done than the interventional. So that station will be right here. So we can rotate, split, take turns, and quickly finish this neurointerventional workshop, and then move on to our evening events, which will be started right here. Thank you so much.
Just wanted to know how many of you have done diagnostic cerebral angiographies by yourselves, hands-on? I think most of you are okay. So it's just we will go by step by step. So can you just enumerate the indications of current of DSA in the current area of CT angio? indication for DSA in the case of neurological conditions, that means digital subtraction angiography for cerebral vasculature. So what is the indication in the setting of the current area of CT angio and MR angio? When we, it is because it is more invasive as compared to CT angio and MR angio, still when do you advise a DSA? Can you just briefly tell the conditions in which definitely DS is indicated as compared to vis-a-vis CT angio or MR angio? So the hemodynamics means AVMs. Whenever you have arteriovenous malformations, instead of doing a CT angio, if you do a CT angio, what you will find is a clump of vessels over there. You won't see the nidus separately, artery, veins and all. So AVM is definitely an indication for DSA. If AVM is detected on MR or AVM is detected on CT, definitely it's an indication. And similarly, fistulas also, dural AV fistulae, evaluation of dural AV fistulae, AVMs, and even keratoconus fistulas also. They can be diagnosed on CT, but what to do next? How can they approach? They can be approached. You have to decide by doing a diagnostic cerebral angiography beforehand, before going for a therapeutic approach, either surgically or endovascularly. So, vascular malformations and fistulae definitely need a DSA before going for intervention. Apart from that, pardon? Vasculitis definitely, and we do see we can detect proximal lesions like diffuse carotid narrowing or M1 occlusions definitely in CT angio, but if they are negative or if you want to simultaneously detect the M3, M4 segment branches where bleeding is seen, that classical appearance you can't get it on CT angio and MR angio. So vasculitis is also another indication. And what next? All comes under vasculitis only. Any other segment you want to indicate? DSA is indicated. Atherosclerosis is predominantly it is proximal vascular disease. So most of the times you will get good picture with CT angio. So we routinely don't indicate a DSA in unless until you are going for some kind of anastomosis or MCA bypass, ST-MCA bypass kind of thing, and you want to evaluate the EC anatomy simultaneously with the MC anatomy. In those cases we will evaluate. But routinely in case of keratoid stenosis and all, we won't evaluate further. But if you want to quantify keratoid stenosis perfectly, going by the guidelines, if it is 50% or 70%, definitely DSA scores over the ultrasound and CT angio. But most of the times the stenosis percentage will correlate.
If CT angio shows total occlusion.
Total occlusion.
Is there a need for doing DSA? Because in MRA, if it shows total occlusion, it's because it overestimates. So we would go for DSA.
Yes, sir.
But if CT angio shows total occlusion, is there a need for DSA? Or
if once you are doing CT angio, what you can do is do a kind of arterial and venous imaging CT angio. If there is very critical stenosis, you will see very slow filling, delayed filling in the venous phase. So if you kind of customize your CT angio protocol, you can diagnose the condition itself there only. And maybe to further delineate it, you can do a DSA, but most of the so if it is total occlusion CTA, even on venous phase, definitely there is no indication in most of the cases. So that is one more indication. So as far as atherosclerosis disease is concerned, proximal vessel disease is concerned, it is not indicated unless until you are going for a bypass. The other indications are even ruptured aneurysms when the anatomy is not clear on CT angio. Sometimes we have seen cases, there is so much of blood in the systems, it will compress upon the aneurysm, and the contrast that you give peripheral in the IV line may not fill it properly on CT angio. So to delineate the anatomy better, or whenever there is CT angio negative SAH, CT angio negative SAH, when with the advent of 3D rotational angio, definitely you have more sensitivity and specificity detection of small aneurysms, blisters. All those things will be made better aware with DSA, with 3D rotational angio, not just DSA, DSA with 3D rotational angio. So to enumerate the conditions in which DSA is indicated in the current setting of CT angio and MR angio, one is vascular malformations, fistulae, keratoconus fistulae, dural AV fistulae, and vasculitis, and the aneurysms for further evaluation before treatment. If it is convincing, the anatomy is convincing on CT angio, definitely you can go ahead with the treatment, whether endovascular or surgical. But if it is not, if it is negative, in a case of SH, or if it is not showing the anatomy properly, then it is indicated to go ahead with DSA. You can convince your neurologist, or you yourself can convince your patient to get it done. So that is the those are the indications, followed by the workup. So what are required for a DSA as a workup? Just enumerate the parameters that are required for DSA evaluation. Workup, what are all required? Okay, because we are giving contrast, so we have to check for this thing. Yeah. Viral markers, because we have to maintain the protocols in the cath lab. Okay. The baseline, like as you said, the renal functional parameters and the baseline hemoglobin, because we can have a baseline hemoglobin upon which if you do puncture site hematoma or puncture site bleeding is there, you can have a baseline hemoglobin to compare with how much loss was there because of the procedure. So hemoglobin should be there, and renal function parameters are mandatory, and apart from that, preparation of the parts.
Is the amount of dye used in DSA in quantity more than what is used in CT angio?
So CT angio, with the advent of newer scanners, they are using around 80 ml. So because it depends upon the pathology. Like if you are doing a very complex dural avium, the contrast is going to be like around 120, 150 ml. But if you are doing a straightforward case of aneurysm with the 3 rotational angio, it comes around 60, 70 ml. It's marginally lesser as compared to this.
But the dye is same?
Dye, we dilute it to 1:1, whereas in CT we will give the pure contrast. For each injection, we will give the same dye with a 1:1 dilution.
Why I'm asking is because of our morning discussion, in which you said neurons are more important than nephrons.
Yes, sir.
So there it's not required renal evaluation. And then why it's required here?
Because it's more, it's more of the clinical scenario, elective versus emergency, rather than the outcome. So it's more about the clinical scenario. So those are required. Parts preparation is very important.
HIV should be done.
A viral screening, nowadays it's a cath lab policy that you should have a viral screening before, so that we can follow up we can put our protocols in place if it's viral positive.
Is ESR to be done? Because some vasculitis patients, if it's
So
active vasculitis, they may worsen. That is one thought.
With the angio, I don't think anything is okay, sir. That is part of the clinical workup, but it doesn't contribute anything to the angiographic evaluation. So that's what we do. So something is abnormal, should we take any precaution before doing cerebral angio, like RFTs are deranged. So, and it is mandatory that we have to do. So the most important thing is like to prevent the contrast-induced nephropathy. The most approved the measures are, one is hydration and NSL system. Those things and all are they are approved. They are all indicated or used at least 12 hours before the procedure. And we can't give just 1 or 2 hours before the procedure and start the procedure. So I'm not going to in depth of CIN. Okay, that is the thing. And if PTINR is deranged, and then you have to replace by the blood coagulation parameters. Then we come to the patient consent. Patient consent will explain 2 or 3 major things. So one of the most common complication, the most common complication that we encounter is puncture site hematoma. That is seen around 2 to 5% of cases. So it can be minor. Sometimes it can extend retroperitoneally into the abdomen. It can be completely missed outside by external examination after the procedure. So if the patient develops tachycardia and dropping pressures, and you don't see anything externally, definitely you should go for an ultrasound abdomen or CT abdomen to see for any retroperitoneal hematoma or pelvic fluid. And that is one complication that you have to explain. The other complications are stroke. Incidence of stroke after diagnosed cerebral angiography has been described. It is very rare, 1 in 1,000 cases. The other things are like contrast-induced nephropathies, contrast-induced reactions. Those can be there, including anaphylaxis. So that these three things should be explained to the patient for the before the procedure. So once the consent is taken, patient shifted to cath lab. I have one actual presentation. I can show you this. Identify these two stuffs and these two vials. Meanwhile, I'll find that. Those who have attended the cath labs also can see or see this one.
Way of angios, contrast MR, I'm talking of MR angios.
Sorry, sir. Pardon me, sir?
How much is the information that one gets from contrast angiogram when it is indicated?
Which one? DSS, sir. Diagnosis cerebral angiogram.
In fact, MRI.
Contrast enhanced MR angio versus TOF, you are saying. So if you want to image the neck vessels with more sensitivity and specificity, definitely CEMR is useful. And if you want to do collateral imaging, definitely CEMR is going to be helpful.
Venous system evaluation.
Venous system evaluation, in case of chronic CVT, definitely it's helpful. We'll whether it is persistently stenosed or there is an underlying thrombus over there. So those things can be evaluated properly.
Advocate should be done wherever is suspected.
So we keep the patient nil per oral for 4 to 6 hours because we are giving the contrast. There is always a chance of vomiting. Vomiting-induced aspiration is there. And as we are keeping the patient on nil per oral, and we always ask the attending sister to give IV fluids in between the range of 50 to 75 ml per hour for the period of NBM. And once the parts are prepared and once the patient is on the table, the most important step that like 50% of the work is done of the diagnosed cerebral angiography is vascular access. Once you get the vascular access, most of the work is done. So the access sites, what we have as compared to the cardiac stuff, cardiac angio, we routinely use femoral artery only. Whereas most of the cardiologists now they have shifted to radial approach, and we do femoral approach only because we are going to cannulate the arch vessels. So it is technically difficult to do radial approach angiogram, cerebral angiograms, because of the anatomical issues. Because we have to cross subclavian and go right in the right angle into the common carotids if you want to do from radial. From femoral, it is very easy to cannulate the arch vessels and go distally and take injections. The most common site is femoral. There are some indications for other approaches like brachial in case of severe aortoiliac disease and coarctation of aorta. In those cases, we will do with using some specific catheters for cannulation of the vessels. Brachial or axillary are sometimes and the vessels are tortuous or you are not able to cannulate and the aorta is very much diseased. We rarely go for carotid, direct carotid puncture. That's maybe in my last 7 years experience I have seen only 1 or 2 cases. That's been done by my teachers. Okay. So once the site preparation is done, we will give the local. So local anesthesia with 2% lignocaine. And then arterial puncture is done. So that is the most important step. This is the arterial puncture needle. Variants are there in the market by which you can do the arterial puncture. This is the puncture needle. It is of 18 gauge thickness. So you have to hit the artery at the level of the femoral head, 1 centimeter medial to the center of the femoral head. So the basic concept is that you have to hit the artery extraperitoneally and infrainguinally. So that, and it should not be too high and should not be too low. And the basic mark, the dictum for that is you take 3 finger bits below a line joining the symphysis pubis and anterior spine. You draw a line with your the prism line with your the fingers. And 3 fingers below that line you can start your puncture. I will show you like this. So this is the caudal end and this is the cranial end. So what you do is with your hand fingers, you can just approximate the line And after that, you make this is a probable line, and 3 fingers below that, you may in the line of femoral artery pulse. In the line of femoral artery pulse, in the line of femoral artery pulse, then you mark that site and give local anesthesia. The site of local anesthesia should be concurrent with that of the site of the puncture. Otherwise, it will be futile. So once the local anesthesia is given properly with a radial infiltrating manner, then you can give a nick. Some people can will directly go with this one, but some people will give a nick, small nick with the blade direct upwards, and then puncture the artery. And once the nick is given, practice varies. My parent institute, what we used to do, we used to dissect the plane of the nick so that the puncture needle will go and hit the artery in a relative less resistant plane, one thing. And if some oozing occurs also, it will easily come out rather than forming a localized hematoma over there. So that was the purpose of dissection, and some people, the dissection of the planes. So once the dissection is done with around 45 degrees, you can do a single puncture or double puncture. You can do a single puncture or double puncture, and single puncture is for more experienced people, double puncture is for the beginners. And with the cannula that is placed between 2 fingers, that is the index finger and the thumb, or you can do like this. So I try to prefer like this. Sometimes I can do like this also. So single puncture, the methodology will be like this, and for double puncture you can hold the needle like this. Once you puncture it, you can see the jet of the blood coming. That is a confirmation that you have hit the femoral artery. Once femoral artery hit, you can see the blood, the jet of flow, and you have to exchange it. That is where the Seldinger technique comes. Onto the wire and place it into the artery. So that is the femoral access. How we do. And once it is placed, you can remove the wire out. Wire along with the dilator. So the sheath has got 3 components. One is the stump, and one is the side arm, and one is the introducing port, and this is the dilator. The dilator is basically, it has a tapered margin so that once it is coursing through the plane of the subcutaneous tissue, it will allow the sheath to pass upon it. Once it is done, you can remove the dilator and the wire end block and keep the sheath in situ in the artery. So in the video, you can show the same thing. So once the puncture is done, the needle is in situ, backflow was there, introduce the wire. Once the wire is in place, hold the wire, remove the needle, put the sheath over it, and insert the sheath in a rotator manner into the artery. Once the thing is done, remove the dilator as well as the wire end to toe, and keep the sheath in situ. Once the sheath is in situ, once it is passing through the subcutaneous plane, there is always a chance that the fat that is present in the subcutaneous plane gets stuck into the sheath. So once this procedure is done, it's always mandatory to try to aspirate the contents of the sheath with a 5cc syringe filled with 2 ml saline, so that any material is there, it will come into the syringe that we have taken up. And after that, you flush it. Once flushing is done, then you give the anticoagulant. That is mandatory for any procedure. We'll give.
For preparation, we have to wash it all with the heparin and the heparin next to saline. Prior to preparation, that is more important. Otherwise, when you give the flap, you form thrombosis in the electrolyte and everything.
You can give it, but in our practice, we routinely don't dip the materials on heparin itself. We just keep 3,000 or 5,000 depending on the duration of the procedure and do it. And the dosage is 56 to 60 international units per kg body weight, and roughly it comes around 2,500 to 3,000 units. And the target is, if you have an ACT machine, active clotting time machine with you, it should be 2 times normal. The normal range would be 100 to 120, and it should be 2 times the normal. And if you want to abandon the procedure, if the procedure is completed so fast and residual heparin is there in the body, and you can detect the residual heparin by half-life over 1 hour, you can reverse the heparin by totally. So once access is done, then you have to, what you have to do, just take the diagnostic catheter along with the wire, the guide wire, what we call it as. Yeah, can you open it? Along with the wire and catheter, just introduce the system as a coaxial system. Take the soft tip, the JP end of the wire, and introduce into the. It is matched. Actually, there is resistance because the wires are hydrophilic wires. So we have to wet them in the saline and then introduce it. Otherwise, they won't pass that much easily. Once it is matched, put it through the sheath, and once it is sheath, always on the fluoro. So don't do anything blindly during angiography. On the fluoroscopy machine and with the guide wire, little bit. Guide wire little bit more distally as compared to tip of the catheter so far because it is not hydrated. So guide wire always should be distally as compared to tip of the catheter, and under fluoroscopy pass it and try to calibrate the cells. That's why what we do. Under roadmap we can do. That's what. The type of catheters what we have is like word catheter we most commonly use. It also we can use, and Pickard also we can use. Okay. Sims also, Simmons also, Sim1 or Sim2 people use. So once you go there, take the injections. The tip of the catheter position is also very important for ICA and vertebral arteries. For ICA, you have to keep the level of
folks are waiting. So much.
But, so that's it. So he's good. He just needs to get used to it.
The system now is probably a month.
No, this is a guy who helped us stupid when he rotates there, he actually sleeps. Because he doesn't want to drive back and forth. He sleeps there, he gets up at 6 o'clock, goes sees the papers, starts running at 6 o'clock. Hello. He's that guy. He's a freaky guy.
That's why I think somebody is smart and that's practical.
We already did our education part, we already did our sharing of scientific knowledge part earlier in the morning and in the afternoon. The trainees took advantage of it, the non-neurologists took advantage of it, and neurologists also took advantage of it. So it is now time to provide the public with what they need to know about the stroke and cerebrovascular diseases. I think it's the events like this that will define how things will turn out over the next decade or two. We all know we are dealing with stroke epidemic at this time, as elaborated in our talks earlier. So in order to address that particular epidemic, the only way is to increase the awareness in the public so they show up timely in the hospital and get the treatment they need in a timely fashion, so they are not left with a disability that not only affects them, but also their families, the community, the country, and the world. So let's get started with our public awareness event. So I would like to request the Indian Stroke Association President, Dr. Dheeraj Khurana. Dr. Dheeraj Khurana, if you are around, please come onto the podium. Dr. Dheeraj Khurana. Kavya, can you check it out? Dr. Adnan Qureshi, the President of Indian International Congress of Interventional Neurology, and who is also the Chief Scientific Advisor of this event. And it is my pleasure and utmost honor to invite Dr. Adnan Qureshi onto the podium. Please give him a grand. Please, sir. Next, it is my turn to invite Professor J.M.K. Murthy onto the podium. Please, sir. I now welcome Professor Subhash Kaul. Please, sir, join us on the podium. I would like to call upon Dr. Dheeraj Khurana again. I hope he's around. Okay. To talk to us, talk to the public of Hyderabad, talk to the public of India, talk to the public of South Asia, and also the international crowd that is here. Dr. Qureshi, please.
It's been a very spectacular event, and I've made many new friends. I've learned a lot of stuff myself, so it's a great personal pleasure to be here. And some of you may know that my family is originally from India, so it's always a great opportunity to visit something that my family actually belongs to. So as Dr. Hiriel mentioned today, the forum really is stroke. And when people ask, what is a stroke? And I think the simplest answer is, it's a life-changing event. Not just for the person who actually suffers the stroke, but for everybody around that person. And we live in an era where we can actually truly say that stroke is a treatable disease. And which is quite different from what was 2 decades ago. Because 2 decades ago, I think that we probably always considered stroke as an untreatable disease. But at least today we are fortunate that that is not the case. But nonetheless, when we talk about treatment of stroke, I think it's very important to recognize that treatment of stroke is not just limited to physicians and the practitioners. In fact, there are several people that are involved in the treatment of stroke or the successful treatment of stroke. And I think it actually starts at a level of the individuals, the patients, the people that are actually around them, their families. Because we heard numerous times today that there is treatment for stroke, but it is a time-sensitive treatment. So if you administer treatment in a timely fashion, it will get great benefit. But if you cause delay, essentially that treatment would have been no value. So essentially, first of all, as members of the public, as members of the population that is at risk of stroke, all of us, we have to recognize the stroke, the symptoms of stroke, so we can actually make a timely judgment that if somebody is having a stroke, and we can call for the appropriate set of help. The next step you take also determines what will enhance and what kind of benefit is to be expected. If you actually call an ambulance to the scene and get the patient to the hospital as soon as possible, you have made a big difference in terms of what can be expected in terms of recovery, what can be expected in terms of disability or even death. So essentially, I just want to highlight that there is so much emphasis on practitioners being the deciders of treatment, but in the reality, it is more than that. It is clearly much more than that. And in fact, the phone call you make to the hospital or the ambulance services, if on the phone you can explain in a way that the person on the other side of the line can recognize that they're actually dealing with a case of stroke, that can substantially improve the treatment times, the time to actually get the necessary help, and even once the help gets there, to actually get the patient to the hospital or the right hospital, so to say. Now, the job is actually done to actually come up with a successful plan for treatment. It has to be a multifaceted plan. It cannot be a plan that's just focused on the hospitals. It has to be more than that. So public education, I think Dr. Hiriel very correctly pointed out, is a very important component of what we can expect and what we should do when it comes down to stroke. I think the onus is also on the hospitals. I think that we as hospitals have to be prepared. When we receive a patient of stroke, we have to be able to act in a time-efficient manner so that we can provide the treatment in a manner that provides the most benefit to the patient. And I think that today, one thing I was happy about was that we actually talked about stroke not just only on the acute treatment, but there is so much about recovery of stroke, so much we have learned about what we can do to maximize recovery from stroke. And we learned about strategies, simple strategies that we classically never applied or never applied in a timely fashion. And now that we are more aware, we can apply and make a big difference in terms of recovery for the patient. I would actually like to emphasize that stroke is actually not a disease that involves only an individual. It is truly a disease that involves the community. And I think that many people would agree who actually had family members that have suffered from a stroke. And I can be pretty sure that everybody who sits in this room, they've seen a family member that has suffered from a stroke. And all of us who will recall the burden, not just on the individual, because clearly the life of the individual is changed, it will never be the same. But the life of people around him or around her would also change, and it will never be the same. So I think that I want us to also think about prevention and not just think about once a stroke occurs, we will provide effective treatment, but actually we can prevent stroke. And I think we talked about some of the risk factors. I think some of the presentations were excellent about risk factors, that can predispose to stroke, high blood pressure, diabetes mellitus, cigarette smoking, perhaps one thing that we can easily implement, high cholesterol levels, even abnormal sleep patterns. And essentially, as a community, as all individuals who are at risk, all of us are at risk for having a stroke, we must be familiar that these diseases can lead to stroke. We cannot ignore these diseases because otherwise the consequences at the end of the tunnel are going to be very severe. And I think that only by acting as role models, only by taking practices that are healthy, we can actually reduce the burden or reduce actually the incidence or occurrence of stroke. I think some things actually which are totally ignored is activity levels. How many people actually know that if you exercise 3 times a week, not severe exercise, just 30 to 45 minutes of moderate severity exercise, you can actually reduce the chance of actually having a stroke substantially. And I think it's something that we totally ignore. And we don't really need to go to the gym, we don't need to go and lift heavy weights. All we need to do is moderate intensity exercise, which can be walking, swimming, or any of those several activities that are actually available and at our disposal. So I hope that I can leave you with a sense that stroke is actually not an untreatable disease. But I don't want you to walk away without putting an adequate emphasis on prevention. And not just us, but the people next to us, the people that we love. That we have to emphasize and make them aware that they must do all the necessary steps to prevent a stroke from occurring. Because even with treatment, there is still death and disability that we see with stroke. And perhaps the best answer to that is to prevent a stroke from occurring in the first place. And I want to leave you with a message. And some of you will actually know the history of Zenat Qureshi Stroke Institutes. Essentially, these institutes were created to honor the memory of our mother who actually passed away from a stroke. And I think that spirit still lives on. And I think the motto of that institute is together we can conquer stroke. And I think it is true to complete it. And I think that what that motto really suggests is it involves everybody in the community, and only then we can conquer stroke. Well, thank you very much.
Dr. Qureshi. I would like to request now Dr. J.M.K. Murthy and Dr. Subhash Kaul to, sir? Yeah, just a few words. Like I said, this is a public awareness event, and you are respected in the community as a leading neurologist in terms of seeing the neurology patients and stroke patients. So I think your message will mean a lot. Thank you so much. Please welcome Dr. J.M.K. Murthy.
I'm not good at giving speeches, but only I told the challenges we need to face in the thrombolysis therapy per patients with them. So I feel this conference should give an impetus to do more public awareness about the stroke and stroke treatment and stroke risk factors management. Thank you.
That was a really short one, Dr. Murthy. Dr. Subhash Kaul, please, sir.
I have to really congratulate Nabil for putting this together. I'm really surprised. In fact, he started his contact with me on email first, and eventually he sought an appointment with me, and I was pleasantly surprised to see a very handsome man with a lot of enthusiasm, and I did my best to discourage him. I always discourage people who come to me, whether it's my residents or fellows and all. Even faculty people who want to join my department, don't join it, it's not good for you, always. And 90% of them are killed there only. But the rest of 10% who join me in spite of me discouraging them, they do extremely well. This is my general experience, because they pass that, they don't care, because they have made up their mind to do it. And I did my best to discourage him. He will remember it. I told him people will not come. You will have to work very hard. It's very difficult to get people to conferences these days. He didn't argue back. He said, we'll try. But I think he, along with Aditya, that is another very silent person. He did the logistics in Hyderabad, and it was a very, very successful conference. I'm very thankful. And of course, he had big people, big stars with him. Adnan Qureshi, Dr. Murthy. In his conference was actually invited about 10 years back, and that time we missed him somehow. But one should be optimistic. 10 years down the line, we are having him in Hyderabad. So I think altogether, congratulations, Nabil. It is all Nabil and Aditya, of course, with Dr. Adnan Qureshi, JMK Murthy and all. And Dheeraj Khurana, the president of the Indian Stroke Association. And everybody, there's a who's who, I cannot name everybody here, Vengamma and everybody. So congratulations once again. I think stroke message, Dheeraj Khurana is the best person to give.
So we now have Dr. Dheeraj Khurana here. I would like to welcome him with a bouquet. And I would like Dr. Khurana to address this particular session to promote stroke awareness, as a majority of the folks here, apart from who were in the sessions earlier, includes lay people. So this is the event that has been added exclusively to promote stroke awareness and spread the message about how we all need to join forces and address or fight stroke. So, Dr. Dheeraj Khurana. Yeah.
Dr. Nabil, and first of all, let me first congratulate you, Dr. Nabil and Dr. Adnan. It's I would say, a moment of great pleasure and honor for us to have you here with us. Just as Dr. Kaul just mentioned, a few years back, we were expecting you in one of the meetings which Dr. Murthy, I think, had organized. And I was also there. We were waiting for your lecture, but we came to know you couldn't make it for that lecture. So it's indeed it's a heartening moment for us to have you here amongst us. And well, as far as stroke message is concerned and the rest of the things, I think just like Dr. Nabil just said, I believe there are some, we have the members of public with us, and are there, just maybe you can just keep it as an informal messages here. We've been hearing since morning. Would they be comfortable with the English? Yeah, right. So we are, in fact, currently our country is undergoing, we are plunging into a big black hole of stroke. Stroke is taking away not only our resources, it is taking away so many of our human resources, lives, and the prediction is that India is going to have the maximum number of strokes in the coming years, one of the highest number of strokes. And the sad part is most of the developing countries and in US specifically, the data where we've got so much of data now, most of the figures of non-communicable diseases as stroke comes in, they are reducing, which is a good thing, but all of that burden is now coming on to us because all of our figures are increasing, And one of the reasons is possibly, I would say, lack of coordinated effort. Pardon? Okay. And possibly, all we need to do is gather our forces, get our act together. And the biggest message that one can all remember as far as community is concerned is to know about stroke. Know about stroke, empower ourselves about stroke, and just knowing the fact that how much stroke can lead on to, the morbidity, the disability itself should trigger a reason for each and every one of us, be it physicians, be it lay public, to spread on the message to your friend, to your family. The first thing that we do is talk to our family. And in fact, one of the very important, I would say, messages given by the World Stroke Organization. For the last 2 years, we've had a campaign by the name of I Am Woman. Now that itself has had a lot of impact. Why? Because the focus has been on women for the last 2 years, and the reason is simple. One, woman plays a very central role in not only the family and but also the society. You can very well imagine a woman taking care of your entire household things. Something goes wrong with a woman and your entire household is gone. And so is this campaign. And as data and even evidence, there is clear-cut scientific evidence, women do not get as much of stroke care as men do for some reason. And one of the reasons is women sometimes do not bother about themselves. They probably ignore certain symptoms. So I think the time has come now that we educate each and every aspect of our public, tell them how stroke symptoms are important. Stroke can be identified by simple mnemonic like FAST. So one is the message of FAST that everyone needs to remember. And now in India we also have in the local language, if one fails to remember FAST, is Bachav. So FAST meant F for face, if you have weakness of the face, A for arms, meaning weakness of the arms, S means speech, and T is time. We do not have time to waste. And Bachav is the Hindi version. B से बाजू का कमज़ोर होना, च से चेहरा, अ से आवाज़, च से चेहरा, और V वह वक्त. So हमारे पास वक्त नहीं है. Let's not lose time. So time is of the biggest essence because the time to treat stroke is very limited. We have a very short window period. So these are the few messages if each and every one of us can carry, the media can carry it forward to the public in a way that if you have symptoms suggestive of a stroke or something which may mimic a stroke, maybe even loss of consciousness, the patient or a person, even if you're seeing a passerby, take him to the hospital, especially a hospital which has facilities for treating a stroke, essentially a CT scan which works 24 hours a day. I know it is very difficult to identify. Sometimes one may say you're probably promoting hospitals which have CT scans, but that's not the case. There's no point in taking a patient to a hospital which has no CT scans. So the future of India, probably we are going to see the map of all stroke centers across India. We as the Indian Stroke Association are trying to promote not only programs like this, but also have taken initiatives where we would be mapping the stroke centers. Hopefully in the next 6 months we should be able to achieve that. That would give access to everyone who would be seeking stroke care, at least to identify stroke centers close by. Then there are other programs which ISA has taken initiatives in mentoring new physicians, young physicians, in the form of Stroke Summer School, where young physicians are mentored. They are given training on how to start stroke centers, how to run stroke programs, and individually too there is mentorship program running for certain centers. So ISA is promoting most of these initiatives where education for both public as well as education for the physicians is on the forefront. And with this, I again congratulate for Dr. Nabil and Dr. Adnan, and even the Indian Academy of Neurology for having supported the cause of stroke, Dr. Kaul here has been our past president of the Indian Stroke Association, so now we have a very close link with the neurologist too. And I'm sure binding together with the neurologist, I sure see a lot of progress coming in the future. And with this, all the best to everyone, and Dr. Nabil, great show again.
I cannot take the credit for myself, to be honest. Things like this are always, almost always a team effort. It's never a one-man show. So I cannot start or end this event without mentioning the people behind this event. But I would like to do that after we finish lighting the lamp. So let's start our event, although we started this morning, but events like this are best saved for the evening. So let's start with lighting of the lamp. Thank you, Dr. Murthy and Dr. Kaul. So going back to the mentioning people behind this event is an international effort with excellent cooperation from local people. And I emphasize that, and will keep doing that until the end of the event tomorrow. So the committee people that I want to thank who are behind this event includes Dr. Komal Kumar from Yashoda Hospital, Dr. Suresh Giragani from Yashoda Hospital as well, Dr. Mullidhar Reddy from CARE Hospitals, Dr. V. Pawan Kumar, who is a general physician, and Dr. K. Subbareddy from Apollo Hospital, Dr. Amir E. Hassan from Texas in United States of America, Dr. Rakesh Khatri from Indiana, United States of America, Dr. Mushtaq Qureshi, who is not here, also United States of America, Dr. Muhammad Rahman, United States of America, who is not here, could not make it due to some unforeseen events. So these are the committee people who are on this thing. We also have international faculty who have traveled to give their lectures, and it's not easy for people to squeeze in their busy time schedules, international travel, and also keep attending and giving these talks. After a point, it becomes too difficult. So I always appreciate, and will keep doing that, who will travel distances to talk about stroke, talk about cerebrovascular diseases, and do their part in addressing the global problem that we are facing. So I would like to request Dr. Adnan Qureshi to hand over the bouquets to all the international faculty here. So I would request Dr. Adnan Qureshi to start with the first one on the list. So, Amir Hassan, please, sir. Dr. Amir Hassan again, and an endovascular neurosurgeon. He practices in Harlingen, Texas, and is one of the successful, young, dynamic, and what else? Everything. Thank you, sir. Thank you for coming here. You to stand here, Dr. Hassan, yeah, please. The next person is Dr. Alex Georgiadis. Please, sir. He is also from Houston, Texas, from Baylor College of Medicine. Next, Dr. Fawad Abdullah from Cairo University, Egypt. Dr. Rakesh Khatri from Indiana, United States of America. Dr. Anil Yella Pragada from South Carolina, United States of America. I have some Indian faculty who I would request, Dr. J.M.K. Murthy and Dr. Subhash Kaul, and I hope I have enough bouquets here because I want to give to everybody. So, Dr. Abhishek Srivastav, please. Oh, he's left, okay. So we don't have him. He's okay. So that will be all, folks. Please give a grand applause for the international speakers. Dr. Qureshi, can you say a few words about these people here, please?
Does it have to be all good? Well, I think that Nabil probably introduced all of them earlier, but I would actually say that it's been a great collaboration, and I think that this is just the first step towards a much bigger collaboration in the years to come. And I think that I would just say that all of these individuals I know very well here in Hyderabad, India, and I think the only thing I would say more is that all the effort that has gone in to set up this Congress from all of you, I think that it's not just a destination that we are coming up to a successful Congress meeting, but it is what this effort has made us. It has actually brought us much closer to a collaborative effort, to a much greater awareness, a much greater recognition of what we can do together. And I think that is probably one of the most important messages that I can get out of all this effort.
So thank you, everybody. So without further delay, let's go enjoy the evening. Thank you for being here. Thank you.